Hey guys, Dr. Andy here today. Today I am really lucky. I am joined by Robert Ridgway. He is a PA, a physician's assistant. Robert, thank you so much for joining me today.
Hey, how's it going, man?
Yeah, welcome. So you're a physician's assistant. That means you take their notes and get their coffee, right?
Not quite.
Not quite. Yeah. Obviously, I joke. You guys are like the backbone right now of the healthcare system in the United States. You guys do. I feel like all the legwork. You do most of the patient encounters. So you guys are really where it's at.
Yeah, you could say that.
I think I read something that said that you guys are like top 10 best professions, right?
Yeah, actually, there's a lot of lists that comes out, every a couple of years or so, top growing professions in the U.S. here
Yep.
and there and stuff. And we usually make the top 10. There's quite often we'll make the top 5, if not top 3 or so. Yeah.
All right. Yeah. So
Yeah.
I know Robert. We went to college together. We went to Furman University down in Greenville, South Carolina. Yeah, I know the beautiful flag. Robert, tell me and everyone else. Tell us a little bit about yourself, about your specialty.
Yeah. So I went to Furman University, graduated in 2011. After that, went to PA school way over in New Mexico, the
What part of
University
New
of St.
Mexico?
Francis.
Okay.
You what?
I was gonna say what part of New Mexico because I have been there.
Yeah, so University of St. Francis, so it's in Albuquerque, New
Okay.
Mexico, which is fun to spell.
It
Graduated
is.
that.
Home of
Graduated
Breaking
there in
Bad.
2014. Yeah. And then, so I've since graduated in 2014, I've worked a couple of different areas of medicine. So started out in urgent care for a few years, and basically then worked in neurosurgery for a few years up in the Washington, D.C. area. And after working there for a few years, me and my wife relocated back down to the South. And
Welcome back.
been working in neurosurgery here ever since. So prior to going to PA school, my background was in emergency medicine, working in EMS. And so I spent quite a few years in the ER, pre-hospital
That's
setting as
stressful.
well. Yeah. I miss it though. Running around in an ambulance is a lot of fun. Got a lot of fun stories from that. So
I'm sure that is one thing you don't have a shortage of is stories on that one.
Absolutely. Yeah. So we'll definitely recommend it. If you're looking into getting into medicine and kind of getting a lot of experience and kind of how the medical field works in the pre-hospital setting, that's a fun time.
Okay.
Stressful though. I can't really recommend it for a career though.
Yeah, I can imagine that people that do that are sort of like a short-lived career and they move on to something else.
Speaking of being hard on your back, I can't recommend being a paramedic.
Right? No, I do. I see tons of paramedics in my office.
Gosh. Yeah. But yeah, so that's kind of my background. And then being a physician assistant is something I got into interestingly. Yeah, I didn't start undergrad actually thinking I'd go into the medical field. Kind of my quick background is I actually started at Furman as a music major. I do a lot of
I was going to bring it up. The music.
Yeah, I started out as a music major. My dad was a physician, and his life advice to me was, whatever you do, don't be a doctor. And
my dad said the same thing. My dad is a chiropractor, and my dad did everything he could, I feel like, to convince me not to become one. And then when I told him I was going to go to chiropractic school, I feel like he got this, this shine in his eye, like he was actually really, really proud of me for making that decision. But at the same time, it was like, all right, man, if you want to make your life hard, go for it.
Yeah. So the quick and short of it is, I was like, well, what would you do? And he was like, well, if I could do it all over again, I might be a PA. And I was, asking him, what in the world is a PA? And he was like, well, this guy down the street that works in our little small hometown is a PA. And I went and shadowed him one summer, and I was like, this is pretty cool, And long story short, I decided I want to be a PA. So went to PA school, and here I am. You want me to get into kind of what a PA is?
Yeah, do that for us. Just because I do think that it is confusing to people that are not in the healthcare fields, like NP, PA, DO, MD. It's all over the place.
Yeah. Oh, absolutely. So two kind of quick ways I kind of get to what a PA is. Number one, if you're familiar with what an NP is, a nurse practitioner, there are some differences, but quick and dirty, they're very similar day to day.
They are.
What an NP is, we do a lot of the same things. So there's that. Another way I explain it to some people who aren't familiar with what an NP is imagine a doctor cloned themselves so that they could be in two places at one time, and I'm the clone, basically.
Yeah.
And that's, one way of putting it.
You basically do everything that the doctor does,
Yeah.
just underneath his license.
I get paid less, yeah.
That's the rough part, right?
Yeah. So PA basically, so I have a 4-year undergrad degree. Mine happens to be in biology. And then a PA, I have a master's degree in physician assistant studies, which is about 2.5-year program.
Mm-hmm.
And then what a PA does is they have their own medical license. It's a master's level license that operates. We practice medicine with a supervisory agreement with a physician or a group of physicians,
Sure.
where they kind of delegate tasks to us to practice medicine. So basically my scope of practice is basically within the scope of practice of my supervising physician. So whatever, I practice in neurosurgery. So whatever my physician that I practice with, whatever is within their scope of practice, with some limitations, whatever's within their scope of practice
is what you're allowed to do.
Scope of practice.
Yeah.
So whatever they see that they want to delegate to me, I can do.
Right.
And so there's a relationship there, and as
it's got to be built on trust.
Yeah, so there's a lot of trust there. So like when you first start working with a supervising physician, there's a lot more of like double backing and checking on what I'm doing, and they've got to learn to trust me and understand what I do know. And one of the most important things in medicine, and probably a lot of other things, is there's this aspect of like the most important thing to know is to know what you don't know, or to understand your lack of knowledge, right?
Right.
And so there's a lot of like your supervising doctor wants to know where is your lack of knowledge, and to know that you know what you don't know, if that makes sense.
It does. So, or the other way that I tell people to think about it is, or when they ask like, how do I know something or anything like that? It's like along the lines of like, well, I know what normal is. Like that's the most important thing to know. Is like, I know what normal is. And if it's not normal and it's inside my scope, then I probably, have a good guess of what's going on. If it's not normal and it's outside my scope, then I know this is not a patient for me. They shouldn't be in my office, and I need to send them somewhere where they can get the right care.
My doctor wants to know that when I'm in over my head, that I know to call them. And say, hey, I need help, or I need information, or I need, advice, kind of thing. And so as we get to know each other more and more, maybe they allow me a little more freedom and let the leash a little longer, kind of thing. Right.
Especially,
but there's always the PA is always, there's always that supervisory, aspect of like, anytime we see a PA running around somewhere, like there's always a supervising physician within reach. Now that's not necessarily like in the building. That may be a phone call.
That can be a phone call away. Right.
Yeah. And state to state, that differs. Like the supervising doc, some states like South Carolina, the supervising doctor just has to be within the state. So they may be hours away, but they just have to be within communication in some way or form.
Now, is that different from an NP? Because I think, NP for anyone is a nurse practitioner. It's like a higher level of, they go to nursing school and then they go for extra schooling to become a nurse practitioner, sort of like to the same level as a PA. I think the difference that I heard was, and that may have actually just recently changed, is that they have to have someone on site with them, or is that again state to state?
Yeah, that it changes state to state. Like for example, South Carolina pretty much treats NPs and PAs the same.
Okay.
State to state, there are differences where NPs can practice a little more autonomously, where they don't have to have a supervising physician, where PAs still do.
Okay.
It's rapidly changing, especially with the physician shortage.
Healthcare world is rapidly changing.
It is, yeah. So it's rapidly changing. In general, if there is a difference, NPs will have more autonomy as far as if there's one of us that can practice without a supervising physician, it's going to be the nurse practitioners.
Okay.
As you can imagine, there's a lot of.
Sorry. I could see something in the future where it's like 10 years, like, or you could be dependent for 10 years, or having a supervisor for 10 years. And then they sort of like, if you pass certain levels of competency, you guys could go out on your own or something like that in the future.
Yeah. And as you can imagine, there's a lot of politics and drama in there. And
there always is.
I have my own thoughts, but I'll leave that for another discussion.
That's a different discussion, right? So I feel like help people understand what the process is, because I think it's easy to understand, especially anyone that's like maybe watching this has been to a chiropractor before. They're obviously very familiar with going to their primary care physician, where they go, it's a 10-minute visit, right? The history, get your treatment, go home. Hopefully that works, right? Whereas you have a totally different process with neurosurgery. So tell us a little bit about that process. What does it look like when someone has been referred to you? Kind of lay that out for us.
Yeah. So usually when we get patients, a lot of times they've been to their primary care, or they're coming in after, an ER visit, urgent care visit, something like that. And they've, they had some acute back injury or something like that. And they've, maybe gotten some short-term medication, some anti-inflammatory or something. And they come to us, with some back pain or something like that. And, where do we go from here? And it's more of, the process of, every patient's a little bit different. And it's more of what's the next step, right? Yep. And we want to work through the process of just because you come to a neurosurgeon's office, or a orthopedic, say it's an orthopedic spine surgeon's office or something like that, doesn't mean that we're going to take you to the OR tomorrow and do surgery, right?
Right.
We do a lot
there's still a process.
Yeah. We do a lot of trying to avoid surgery. Surgery is kind of a last resort. We do a lot of trying to avoid surgery, actually. And so a lot of that process is trying to, start up the, how do we get you into some conservative treatment? So we trying to, the first step is to really sit down with you and see what's going on. Where's your pain? What's going on? What happened? How did this start? How long has it been going on? Where's your pain? Where's it going? And then kind of get your story, and where can we turn you to start this kind of process of further conservative options? Because there's a lot of conservative options out there for patients, whether that's, physical therapy, just exercise, you're a chiropractor. There's all sorts of things that patients can do our goal is to avoid having to do any sort of surgery, and and just try and turn them away from surgery to something to get them some pain relief.
Yeah. So when someone comes to you, have they already failed conservative care, or it's actually you're getting them early on from the medical doctor who maybe has done some NSAIDs or something like that?
Yeah. Honestly, it's a mix.
Okay.
Sometimes we get patients sometimes that are come straight from like, I went to an urgent care and they gave me some Flexeril, and this is the first time I've been seen since the urgent care. And then other times people have come and they've already seen, they've gone through physical therapy and pain management, and they've seen another neurosurgeon and they're here for a second opinion. So they've, we get the whole mix of, some have already failed conservative therapy. Some are just at the very beginning of the process. Yeah.
So how do you help weed out people knowing, like we were saying, knowing that people should start with conservative care first, and then as conservative care fails, going all the way from starting with the most, conservative, which is, I'm not going to say rest, but trying to take care of those problems at home, because rest is actually a pretty bad, treatment plan. But trying to fix the problems at home with self-care, all the way up through, then exercise and physical therapy and chiropractic, massage, acupuncture, NSAIDs to drugs to surgery. Are you able to identify people pretty early on that you feel like, all right, these people are probably going to end up on the table or need our care? Or is it sort of a mix?
Yeah, it depends. It's everybody's a little bit different, and it really just depends on how they present.
Yeah.
And everybody presents with a different history. Some people, sometimes people come in with a history of they've had surgery before. Maybe they've had
Okay.
a herniated disc before, and they present with very similar symptoms that they've had before, and they're at risk of something similar that they've had before or something like that. Or it depends on how their age, or the nature of the injury, or this and that.
Right.
So you can kind of I hate to say put people in buckets and things like that, but you can
You're not
kind of
supposed to, but you do at the same time. Yeah.
Yeah, you can kind of stratify that a little bit, but it really
It's
is
called
just
triage.
yeah
in a way.
triage to an extent, but
Right.
really it's sometimes it's hard. Every injury is a little bit different, and so it's a lot of times it's really just kind of seeing how things play out, because we're really trying. It's really to try and to see how conservative therapy plays out a lot. We really try not to rush people to the OR unless it really is like very obvious that
Right.
this is
They can't pee, they can't
that
poop.
like something like rapid neurologic decline,
Right.
or an unstable joint or something that's
Right.
we got to do something now or never kind of thing. We really try and give it a chance. The body's pretty good about healing with if you do good conservative management, in a good manner. We try and give them a chance, because anytime you take someone to the OR and do surgery, that's not risk free. There's inherent risk with doing surgery. So
right.
And medicine's all about risk benefit, weighing that risk benefit ratio, and surgeries inherently carry some risk with it.
Right.
So
there better be a huge benefit. They better have a lot of. They must be significantly bad enough that it warrants it.
Yeah. So if there's any chance of this getting better without surgery, like we generally try and let's try and go that route.
Sure. So without putting people really into buckets too much, would you say then that the two most common things that come through that maybe people are in the right place in terms of seeing a neurosurgeon is previous surgery and neurological deficits? And for people listening, neurological deficits is like weakness, tingling, burning pain. That's kind of sort of different from like regular back pain or regular neck pain, which is more achy, sore. It's more of like lightning-like. Would that be more true?
Yeah, and I guess I see like neurologic deficits is like more like like you were walking last like 2 months ago and now you're in a wheelchair.
Okay,
Not
so
strictly because
progressive
of pain, but more like true like becoming paralyzed kind of thing. Like
okay.
And even like tingling and things like that can happen, but even that can medication can sometimes be, you can manage that with medication sometimes, not necessarily, that's not even always a surgical thing. But it's just difficult to really say. Again, it's hard to say specifically without seeing patients and doing a physical exam, and especially without imaging and things like that, to say everyone's so individual. It's hard to say in a generalized way. Everybody's so specific.
So if people are, unfortunately, if they end up in your office and the case is preventable, what should people do on their own, as well as follow your advice to hopefully prevent themselves from ending up on that table?
Yeah, for preventable thing, I think the biggest thing is really just exercise.
Yes. Thank you so much. Thank you so much for saying that.
I think probably the biggest thing that people don't realize is just, and exercise doesn't mean just going to the gym and like pumping iron and, leg day and getting your arms big and buff. Like core strength and your back is surrounded by all these muscles that help support it, and just like core strengthening and things, and diet goes along with that as well. Just supporting your I mean, it's the things your mom taught you, you know, back mechanics and,
Yep.
you know, sitting up straight, maintain, you know, good posture. Just, you've only got one back, so take care of it.
Right.
It's things that you can do today that down the road, your back will thank you for is kind of the easy thing to go for. That just exercise and just, I don't know another way to to put it.
No.
Yeah, exercise. One thing that just comes to mind that I see some people doing that really kind of irks me is people will start having back pain, and so they'll go to CVS or Walgreens or whatever, and they'll get some over the counter brace, right?
Yeah. Don't do that.
And they'll say, "Hey, I've been wearing this brace because I have back pain," and they'll find that it helps. And sure enough, yeah, it helps with their
short
pain.
term.
Yeah, exactly. And so it helps with my pain. And so, but then my pain got worse. So I wore the brace more. And so, and before they know it, they're just wearing the brace all day, every day for their back pain. And how long have you been wearing the brace? Well, I don't know. I was wearing it, you know, here and there, but then now for the last like 5 months, I just wear it all the time. And what they don't realize is they have no core muscles left.
No.
Their brace is all they have. And so
no, exactly. The brace is the crutch. Yeah. It allows everything to relax and not do its work.
They have no strength around their back muscles anymore at all.
Right.
And so they're so reliant on the brace. So it's like, if you have an acute injury and maybe the brace is helpful for a little bit, maybe fair enough. But like people will get so reliant on back brace. Like don't go to CVS and buy a brace. Like if like I hesitate to even recommend it for even a temporary amount of time, just because
I typically don't like it when someone comes in and says like, it really helps me like on my job, because my job involves a lot of lifting and twisting through the low back.
Yeah.
I'm like, fine, but make sure like it comes off like as soon as you get off shift, because that's not good long term.
Yeah. So as far as like preventing things like exercise, and be so careful about braces. Like I said, I basically just don't ever recommend a brace. Yeah.
Okay.
Unless you're PostOp. Like PostOp will recommend braces, and if you have something like a compression fracture, but be real careful. Like don't go to CVS and buy a brace. I see patients doing that, and then you destroy your core strength, and your spine just has no support, and that tears it up.
What I tell people, and it's probably my biggest finding, is that almost anyone that comes in my office with back pain has poor core integrity. Like they have, like, I don't care if you have a 6-pack, like that's like core strength. Like I'm talking about like core integrity in terms of being able to have good motor control, being able to resist, rotation and lateral flexion, or bending side to side and bending forward and backwards. Like if you can't control those movements, like I don't care if you can do, 1,000 sit-ups or have an amazing 6-pack, it doesn't matter. You're still just as likely to injure that low back. So, what you were saying in terms of the exercise, that is just a huge part. Like I view it as like, a lot of times I look at things as very biomechanic. So, I mean, like most chiropractors do, it's all about proper movement. Your body is designed to have a certain level of range of motion. And if you don't have that good range of motion, you have pain maybe with that, poor range, then it's usually coming from, joint dysfunction, meaning joints not moving the way that they're supposed to, or muscles that are too tight. And over time that, causes wear and tear, and it causes a lot of buildup to the point where now you are in either, typically more chronic type pain, as opposed to having like an inflammatory car accident type pain, right? What you're missing in that formula is you're missing movement. You're missing proper range of motion. So my first line of defense for everyone is, obviously the chiropractic manipulation in terms of helping individual joints move better, but it has to be coupled with core integrity type exercises. And even on top of that, go out and walk, even pick up a heavy, kettlebell. I have no problem with telling patients to pick up something heavy and repeatedly put it back down to not just gain strength, but also help them mentally understand that they are in fact strong. Because that goes to the biopsychosocial model of pain in terms of like helping, not to catastrophize patients, not to tell them that they're weak and that they've got this huge issue that they need to see me 1,000 times for the rest of their life. but to help them understand that they are strong, they've got this, and they will get better. Because you tell a patient that, and they will get better.
Yeah.
Sorry, that's my rant.
No, you're fine. You're fine. Yeah.
So it was really refreshing to hear what you said.
Yeah. I just say it's like you walk into a room and they've got this CVS brace on, and it's just like immediately I'm just like, oh no.
Oh no. It's going to be one of those.
Yeah. Yeah. Yeah.
All right. Well, that's the theme of the entire interview is if anyone takes anything away from this, it's don't use a back brace because you might end up at a neurosurgeon.
Yeah. They have their place, but that's not it.
Not it. And probably not the one from CVS.
Yeah. Probably. Yeah. No.
Yeah. If you have one, it better be given to you from someone who knows what they're doing.
Yeah. Yes.
So one last question for you. Do you see a lot of patients post-op as well in terms of helping to manage the post-op, or is it all more on the pre?
Yeah, no, we see a good bit post-op. Mainly, most of the patients that I see post-op are kind of immediately post-op.
Okay. Before they're handed off to the physical therapist?
Yeah, so post-op, and then a lot of it's like post-op, mainly just check their incisions, make sure they're healing well and things like that. And then a lot of the like 6 month, 1 year, stuff like that post-op are mainly with the surgeon at the current practice that I'm at. And just to kind of check, make sure they're doing well and things like that. And that's mainly, so most of my post-op patients are your incision healing well and not infected and taking stitches out and things like that. But
what's your biggest piece of advice you give them? Keep it clean.
Yeah. Or really just stay mobile, because a lot of people after surgery, whether it's a small minimally invasive thing or, some big fusion or something like that, there's a tendency of sometimes like, oh man, I just had surgery, so I just want to lay around all day and do nothing. It's like, no, like even though there's pain, there's post-op pain, get up, move around, work through it, do things, because it's painful, but getting up, move around is going to help your recovery.
That's actually a huge change in healthcare. Maybe 20 years ago, your doctor maybe told you to go home and rest and do nothing for a week. Now it's like the second surgery is over, it's get up and move around.
Yeah, we want you up moving around some, and we'll have usually depending on the surgery, a lot of times certain surgeries will have them, and this is the point where some of these we will have you in a brace, some pretty substantial braces and stuff, but we do want you moving around, walking around. I mean, not running marathons or anything like that, but we want you up walking around the house, maybe taking walks up and down the street and things like that. I mean, I wouldn't go to Six Flags and hop on a roller coaster or anything.
Probably not.
But yeah, people will just kind of, I laid on the couch for the last 3 days, and things. But we do want you up, moving around, and being active, because that's going to help you, recover a little better. Now we don't hop you out and send you to physical therapy immediately. We do give you a few months to recover, but and then once you get you up, then our goal is get you up, moving around, a bit, and then after a few months, get you out of that brace. You need the brace, but after a few months, try and get you out of the brace as soon as we can, so that you can go to physical therapy and rebuild that core strength, and then get you back, into physical therapy and
I love it.
and things. But yeah, so but most of the post-op patients that I see is mainly making sure that wound's not infected and that you are up, moving around and doing all right.
Good.
And
I hate that
it's mostly like within a couple weeks after surgery.
Okay, good. I hate that cliche, but isn't it just so true, that whole movement is medicine thing? Like, I feel like everyone in musculoskeletal care, whether anyone related to spine or orthopedics or anything like that, it's like everyone just says movement's medicine, movement is medicine. I mean, yes, it's absolutely true, but it's like in the same way in like healthcare 10 years ago, everyone was saying the words like wellness.
Oh gosh, yeah.
Yeah, it's like wellness, the key word now. But it is true. I mean, like, don't get me wrong, just because it's like so cliche, it is actually extremely true. Movement is medicine.
Yeah, keep moving. Yeah.
In terms of both pre and post-op now.
Yeah, pretty much.
Yeah. All right. Robert, honestly, thank you so very much, both for me and anyone, watching, listening. Thank you so much. I appreciate it today.
Yeah, no problem at all.
All right. Thank you much. Appreciate it. Bye.
Yeah. All right. See ya.